Welcome to the conference session titled Living with High-Risk MDS. Thank you for joining us. My name is Alice Hauk, Senior Director, Patient and Health Professional Programs, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speakers cannot answer any specific questions related to your health care. Today's specialist is Namrata Chandok. Dr. Chandok is a hematologist-oncologist at Sylvester Comprehensive Cancer Center at the University of Miami. At Sylvester, Dr. Chandok works as a part of a multidisciplinary team treating patients with leukemia and myelodysplastic syndrome and myeloid malignancies. She earned her medical degree from the George Washington University School of Medicine and Health Sciences, completed a residency in internal medicine at Tufts Medical Center, and completed her fellowship training in hematology-oncology at Yale University School of Medicine. With that said, welcome, Dr. Chandok.
Thank you. It's my pleasure to be here and talk about higher risk MDS. And thank you for all of you for being here. So just to start, I created a sort of structure for this presentation, but we're happy to sort of meander off as needed just to make sure we're answering everyone's questions. And as with the previous talk, Alice, please feel free to interrupt me if things come up. So just a quick roadmap of what I have planned is to talk a little bit about the bone marrow going from normal to abnormal, how we determine risk in MDS, which we talked a little bit about in the previous session, but more as a reinforcement or for anyone who joined in. What is higher risk MDS in particular, and how is this different from lower risk disease? And then what are the differences in the goals of treatment in higher risk disease from lower risk disease? We'll talk briefly about what's available as well for higher risk disease right now, and then talk about some specific considerations, because as doctors we're often talking about, the blood counts or the bone marrow or blasts, which in terms of practical applications leaves something to be desired. So we'll chat a little bit about those things too. So as I mentioned, the first step is what is the function of the bone marrow? And many of you have heard this from Dr. Sekaris very eloquently a few minutes ago. But the main function of the bone marrow is essentially to make these three cellular components that are key to our function. The red cells, which help carry oxygen to the various parts of our body, platelets, which stop us from bleeding, and then the white cells, which are essentially our entire immune system. So anytime we have a cold or a cough or fevers, these are the cells that are fighting. Now what happens in particular in MDS is it's almost like the soil of the bone marrow is poisoned. So you have these cells that are pretty unhappy, the progenitor cells, meaning the cells that start everything, also called stem cells sometimes. And there are many different steps in this process, but as we've already discussed, age is one of the things that makes your marrow function a little bit abnormally because you collect mutations over time. But other stressors that were previously mentioned also include things like chemical exposures, radiation, and then many other things that have been documented like smoking or other stressors on the body. And slowly what happens is having a mutation on its own doesn't necessarily mean that your cells will become abnormal, but the cells with the mutations sometimes develop an advantage. So if you're in a stressful situation, not necessarily emotionally, but you get sick, and then these cells can grow a little bit better than the normal cells, they'll start to basically expand. And when those cells are expanding faster than the normal cells, they develop what we call an advantage, essentially. And over time, decades really, the stress and inflammation and additional mutations can end up causing MDS. Now, we previously talked a little that MDS in particular isn't really one diagnosis, right? It's a whole spectrum of diagnoses. It's a whole group of diseases that are all clumped into one. So when your doctor tells you you have MDS, it's not really just one thing. There are very specific things we're looking at, and everything is a range in terms of prognosis, diagnosis, and how you're being treated. But with the two main ways that things go generally are that your stressed cells, the cells that are not functioning that well, as things get worse, they stop making that population of cells that you need. So the red cells, the platelets, and the white cells. So that's called bone marrow failure. And the other way it can go is that the white cells that are abnormal can actually become more abnormal and start growing in an uncontrolled manner. And that's where you end up developing acute myeloid leukemia. So the two big pathways that we're thinking about people, progressing is either not being able to produce enough cells, which is bone marrow failure, or producing too many cells but the wrong kind, which is acute myeloid leukemia. So what does this mean from a practical perspective? So as patients tend to progress over time, for those who are not making those normal cells anymore, they can become more transfusion dependent, right? And in the prior session, Dr. Secker has talked about the three very distinct ways that you can control for some of the things by treating what the underlying problem was. If you have anemia, managing the anemia, meaning low red cells. If you have low platelets, there are drugs that can help push your platelets up. And if you have low white cells, you are at a higher risk for maybe developing some infections. And how we tend to manage that is if you're getting frequent infections, then starting you on some medications just to prevent them. So prophylactic antibiotics. We don't do that on every single patient, but if you start having issues with that particular type of cell, then that's something we move forward with. So in that bone marrow failure situation where you're just not producing enough, you get those treatments, and then you get transfusions if none of those are working down the line. The other way you can go is acute myeloid leukemia, which was the uncontrolled white cells. And uncontrolled white cell growth is basically like bullies in the play yard, where essentially those cells keep growing and they keep their friend group close and they crowd out the other cell types. So basically you're not able to produce the other cell types. In bone marrow failure, what's happening is more that you might have the space there, you might have all of the resources, but the environment is so toxic that your cells are dying off basically. Does this all make sense so far? I think this is a little bit of a review, so we're going a little faster. Great. So determining risk is a big thing in terms of deciding, what you're going to get for treatment, how you are going to progress, and what is important in terms of your management. And how we do this is primarily looking at a host of factors, right? I've mentioned a few things, which are your cell counts. But the one thing that seems a little bit harder to understand in general is a cytogenetic group. And we mentioned this previously, but what cytogenetics are and what your doctor might end up telling you a little bit about is your chromosomes. Now, what is chromosomes? It's basically the genetic material that carries all of those mutations and things you hear again and again in clinic. And everyone has chromosomes, okay? But these chromosomes are usually in a normal pattern for men they're 46XY, meaning you have 46 sets of chromosomes, and each one does a little bit of a different, they have slightly different function. And then in women, it's 46XX, okay? So what happens sometimes in MDS is that a little piece breaks off. They kind of get scrambled when they're splitting from each other. When the cell is dividing, it's not dividing correctly. So you might end up having a number that's abnormal, might lose one, might end up gaining one. And a lot of times when we're looking at your cells and we're looking at your bone marrow biopsy results, they're just not right. So this is a big factor in determining what is your risk. Because some of these losses or gains, or just changes, can be consequential in terms of they can make your prognosis worse or better, or they can predict how your disease is going to progress over time. So this is sort of the hardest one to grapple with. The others are important things that we've already talked about, meaning your red blood cells or hemoglobin, without transfusions, so what you're producing on your own, your platelets, which again are the cells that stop you from bleeding, also without transfusions. So sometimes you've had a transfusion and the number is artificially increased, but if you're just making your own, you want to know what that general level is. And it's pretty clear, because if you're at a level that you need a transfusion, you're already pretty low. And then another type of cell called the absolute neutrophil count. So this is one particular type of white cell. So oftentimes when we're looking at white cells, we're looking at a conglomerate of many different types of cells, because each type of cell has its own capacity to fight different types of infection. Neutrophils are these cells that fight big bacterial infections, and they're like the first line of defense when you're starting to get sick with one of those. So it's a really important cell type, and it's important we know in terms of figuring out MDS. And then the latest change is actually including particular mutations. So when I was talking about cytogenetics or your chromosomes, those are big changes, big things, big groups of genes being lost or gained. But mutations are like particular spots in your DNA where there's a little bit of a mistake. And some of these small mistakes mean nothing because we have a lot of DNA that's not doing much. But we also have a lot of DNA, a lot of particular spots that can make your cells more or less susceptible to creating that bad cellular environment. So some of the mutations that we have identified and we know end up causing problems have been recently added to figuring out risk. Now, a lot of this goes along with how someone is feeling, because if you think about it, for someone with a low hemoglobin, the usual symptoms are pretty vague, but they end up feeling very tired. Or you can't do the same energy activities that you used to because you just are devoid of energy. Or you're sleeping more than usual. So things that are pretty common, how you feel often reflects how severe your disease is. It's not absolute, but it is a frequent thing. With platelets, I know we talked a little bit about them being not the most important, but I would say they are really important because a tiny, tiny bleed in the brain is a stroke, right? And can turn into something really massive. So I think it's important to keep that in mind, that keeping all of these cells in a reasonable range where they're not causing problems is really important. And then again, with the neutrophils, oftentimes people will end up having more frequent infections. So the most common of these is, of course, the hemoglobin going down and having that, just general fatigue, tiredness, not being able to do your normal activities. But all of these have an effect on quality of life and, function in general. So all of those things basically went into something called an IPSS score and the various versions of those. So over time, that's evolved a little bit, but the core structure has been the same, which was looking at those blood counts and then looking at your cytogenetics, And based on that, it actually breaks things up into 5 categories, right? So you have very low risk, intermediate risk, and then high and very high. Now, if you see on this slide, I have 6 broken up, and that's primarily because a lot of times the lower intermediate people or people with a lower score, when you plug those numbers in, might deviate towards a slightly better prognosis or like length of life or things like that. So even though intermediate is a big category, you can break it a little bit when you're looking at how we do research. And that's why it's 2 on this slide. But in general, when we're thinking about treatment for patients, we're thinking about, well, are you lower risk, which is grouping together the very low, and then some of the intermediate 1, and then, or are you higher risk? So intermediate, high, and very high. And based on this, we can make some assumptions. Now, of course, every single patient or person is different, and we have to keep those specific factors in mind because, as we know just from the last 20 years, that science keeps evolving and keeps changing. And one of the big things that we've learned recently, based on some of the scoring systems that we talked about, right? So the IPSS has evolved, and one of the latest versions is adding those mutations in. And when they did that, when they added that to the score and they tried to restructure, well, who falls into which category, it turns out that some people will actually be a little bit higher risk based on that additional information we just put in, and some will end up being a little bit lower risk than we thought. So grouping patients in the right, I guess, bucket is important because it gives us a little bit of a framework. But even within that context, we have to remember as physicians or, as people having a conversation with patients, that every person is a little different. And the trend that you're following is also important to keep in mind beyond these scores. So what we're going to focus on now a little bit more is high-risk disease or higher risk disease. So these groups from intermediate 2 to very high. And how is this different? Well, one of the things he mentioned is some of the mutations might be a little different. So you had those isolated SF3B1 mutations, right? Where he talked about having a ring and cell types being a little bit different. Well, when you have isolated mutations in that, you might be very good. But then somebody had asked a question about blasts, those immature cells that develop in the bone marrow and are abnormally high in patients with MDS. That tends to push you towards higher risk. So most patients with excess blasts or too many of them are higher risk. And how we look at this ends up being a little bit different too, because you're looking at the cell counts, but then you're also looking at how are the blasts doing? How are people, are you increasing in blasts or decreasing? Because even though it's an artificial line, what is AML versus what is MDS? As we know, the higher you get, the closer you are to that diagnosis of acute leukemia, right? And how you manage acute leukemia, while the general principles are the same and the types of cells are the same, is a little bit different, primarily because that can become an aggressive disease faster. So again, the big difference between higher risk and lower risk, and this is a really busy slide, but I'm going to walk you through it, is how people do from 2 big factors. 1, in terms of survival, and 1 in terms of freedom from AML. Meaning, like we talked about before, you take 2 paths, right? You can start having not generating enough cells and needing more transfusions, or your blasts can increase and you can go down a path where you develop acute myeloid leukemia. And so what this is showing is, when they did that risk scoring, the IPSS that we keep mentioning again and again, the patients who had very low risk disease, they looked at survival first. And then the patients who have very low risk disease, which is the green line, you can see a majority, or many of them, at least half of them, are surviving 12 years, right? So your survival with low risk disease is much higher. And that makes sense, right? That's why it's called low risk and it's treated differently. But then if you look at the blue line, which is very high risk, as you can see, it does this like cup type curve, which means that of those patients who were looked at, most of them, it says 0.2, which is about 20%, right? Most of them were dying before 2 years, which is terrible, right? So while we labeled everyone MDS, all the MDS was not the same. The folks with the very low risk were actually living a good number of years. They're doing 12 years, and for someone who starts out at 80 years old, you're at 12 years and, half the people are still there. That's great. But the folks with high risk, you have to treat them a little differently or, manage them differently because their chance of dying from their disease within that first year or two is very high. Of course, all the other stages are sort of in between. So very, very low is obviously great. And then it goes in a sequence. So low is the gray line, intermediate is the orange, and the deeper the curve, basically, the worse the survival is when you're looking at this graph. Now, from an AML perspective, right, we keep saying blood counts are important, and the other thing is not to turn into acute myeloid leukemia. So similar to survival, you want to try and keep patients off a path where they're developing acute myeloid leukemia. And for people with very low risk disease, basically acute myeloid leukemia tends to be less of a problem. There are still some folks who will go from very low risk disease and over time develop mutations or other problems which will lead them to developing leukemia, but it's a much lower number than people with very high risk, which again was based on those mutations, the abnormalities in your genes, and your blood counts when you first got diagnosed. So in both cases, your survival is better with very low, and your risk of progression to acute myeloid leukemia tends to be less with very low. And on the other end of the spectrum, you treat very high, almost the same as you would acute myeloid leukemia, because most of those patients are going to have some major complication within a year or two. So what are the goals of treatment, and how is this different between low risk and high risk? Well, in lower risk disease, our bigger problem, because we're not as worried about you developing acute myeloid leukemia, is how do we keep your blood counts high enough that you can enjoy a normal life? And so the treatment ends up being on improving quality of life and making sure you don't become dependent on those transfusions, right? Because transfusions they seem not like a big deal, but they're a big deal. You have to go to an infusion center. You have to sit there for 6 hours. It's a big change in your life when you're spending a day or two, even if twice a month, in a clinic. So our big goal is to make sure that you're not getting to that path and to try and minimize any interruption in your normal functioning. But in higher risk disease, we know that many people are going towards that acute myeloid leukemia, right? And are going towards bone marrow failure, those two things that end up hurting people long term. So our big goal, even though there end up being more interventions or more medicines, our big goal in that situation is to try and prolong survival, in addition to trying to maintain as much quality of life as we can, and also to minimize transfusion dependence. But basically, we think about it in a way as higher risk, higher reward, because you know that without a treatment, things are going to progress. And so treating the problem becomes really important. And in the short term, we know that treatment can actually, add side effects, it can add a lot of headache, and people are not used to that. But in the longer term, treatment is really important because things are going to progress in the wrong way. So how do we treat this high risk? Actually, I want to take a quick pause to make sure we're all on the same page and, I'm answering everyone's questions. So is there anything that didn't make sense so far? Okay. So how are we managing patients with higher risk disease? Well, like I said, treatment becomes really important, right? So we want to move forward with some sort of therapy for patients with higher risk disease. And what that therapy is tends to be actually a little bit simpler than, when we're just managing the particular blood type that was abnormal. So Dr. Sekres mentioned a whole host of drugs that we end up using for lower risk disease, because that's more focused on what particular symptom you have. Meaning, is it your anemia? Is it your platelets? Is it, the white cells? Your treatment was very focused on the cell type that was not necessarily working very well. But in the case of higher risk disease, as a generalization, we often have problems in more than one cell type. You often have blasts, which are those abnormal cell types again. And so our goal is really to change the environment of the bone marrow somewhat, that you have the opportunity to, intervene with the problem and maybe get rid of those blasts, make the environment a little bit more hospitable for normal cell growth. So our mainstay of therapy outside of clinical trials tends to be this group of drugs called hypomethylating agents. And I'll talk a little bit more about how these work and then what drugs we actually have. But one thing I really do want to talk about right now in terms of management for higher risk disease is that there's a lot of studies looking at targeted drugs, meaning drugs that look at particularly what problems exist in your MDS and how do we sort of focus in on those, or on big clinical studies that look at things that have been brought up before, immunotherapy. How can we make that more efficient for us? Or how do we change the environment of the cells, not necessarily targeting the cell itself, but the other cells that cooperate with it, right? So the makeup of your bone marrow is essentially like a village, and every different cell has a role. And in some ways, all those cells might be abnormal. So sometimes we can target not necessarily the cell that's the problem or causing those excess blasts, but what's around it. Because if we make the environment unfriendly for that poor cell, we can actually fix the problem without trying to target that cell directly. So there are many ways we're going about this problem. We're hoping we get a big leap in a future therapy because, like I said, our options are kind of, in terms of approved drugs so far, are somewhat limited at this point, right? We have one class of drugs that works, and we know that help patients, but we need to do better because, these drugs work, and they work in a subset of patients, so only some people will respond to them, and they're not permanent, so they work for a short period of time, essentially. So what do we do after that? And that's where the scientific sort of drug discovery is going in this area. So clinical trials end up being a huge part of higher risk MDS treatment. They're a big part of even lower risk because we keep needing new therapies for everyone. But in higher risk, there's a huge focus on trying to drive this field forward. So this is a little bit complicated, but I'll try and walk you through it, and I'm more than happy to answer questions. So that little purple thing you're seeing there is the cell. And inside that cell, you see another purple circle, which is the nucleus, which houses all your genetic material. So everyone in this room in society has these stem cells where all your genetic information, all of what you're going to pass on to your kids and everything is stored. And it's all stored in DNA. So DNA is that material which has all the signals in it, which tell your body, do this or do that, or, this is where your hair color is going to be, your eye color is going to be, all the characteristics that make you. Now, there's a shocking number of genes that are actually the same in all of us, and how we turn them on and off is kind of what makes everyone a little different at different stages of life, okay? So how that DNA is wrapped up, as you can imagine, each cell is so tiny and DNA is so long, it's wrapped up really tight. But how it's wrapped makes a big difference on what genes go on and what genes go off. So basically, what is actually making you what you are today, right? And what happens is in MDS, one of the things, there are many things that are happening, because you can have like a mistake in the DNA directly, which is causing that MDS. But beyond that mistake, there are so many other things contributing. So beyond that little mistake, how that DNA is wrapped up makes a huge difference in terms of what's being expressed and what's not. Meaning what signals you're sending out, what proteins you're making in your body. And the hypomethylating agents, so the drugs that we're using for treatment, are basically changing the way your DNA is all folded up and what's being expressed and what's not being expressed. So that's how this class of drugs works. Now, I can tell you that this is only part of how they work, because there's a whole part that we don't even understand. But this is how mechanistically we think these drugs work. And basically what that process of folding and expression is called is epigenetics. So basically, how active are certain genes? So that's what these drugs do. When you give that drug, it turns certain things on and it turns other things off, trying to make it more like a normal cell. Now, the one that we use most commonly in the US, or you can get a whole host of them, but the oldest one and the approved drug is azacitidine. And why we use this is because we know that it improves survival, okay? So if you look at the two lines, and you don't need to understand all of this because it's complicated and it tells you how many patients and everything were on this study. But basically, this study was about 350 patients. And what they looked at it was patients got azacitidine or they got nothing, conventional care, which at that point was very little, right? They got transfusions, they got support, they got everything else, but they didn't get treatment. This is before the drug was approved. And at that time, they looked and saw how those two populations matured, right? So the folks who got the azacitidine, were they living longer or were they living the same? Did they have more side effects or was it about the same? And what ended up happening is that if you look at this says months from randomization. So they were looking month by month, how many patients were actually staying alive. And they saw, as you can see, the azacitidine line, which is the blue line, is up. So that means they were actually surviving longer, which is why this drug got approved, right? People were living longer. Now, in addition to looking at how long people were living, they also looked at how their quality of life was affected, because that's a big part of things, right? And quality of life didn't seem to change too much. So of course, people had some side effects. They might have gotten constipation, they might have been more tired, they might have had other issues during treatment, but there was no significant difference, right? No big difference that was enough to stop the treatment. And that's how that drug got approved. The other thing they looked at really carefully was that in that azacitidine group, or the Vidaza group, Were people bleeding more? Or were they having more infections? Because something, hopefully your doctor will tell you if you have MDS and you start treatment, is that before your counts start getting better, sometimes they get a little worse. And that's just the effect of the treatment. It's killing off those bad cells, right? The numbers might get worse before they get better. So in the study, they looked at, are those changes, or is that number getting worse actually making prognosis worse, or is it making bleeding worse or infections worse? And it didn't. So that's why this became, in the early 2000s, basically, it became our standard of care drug, meaning a drug that was approved and stamped by the government that it's safe and effective and our best therapy, right? There are other cousins to this drug, and I'm not going to show specific data on each one, but the other cousins are decitabine, or Dacogen, as some people might call it, and then a more recent drug, which is an oral version of decitabine. Because anyone who's gotten this drug knows that it's either IV or injections into the belly, right, from the Vidasa. And that can be uncomfortable, and it's a lot of visits to the doctor. So one of the big changes was creating an oral formulation and trying to make it live longer in your system, because these drugs are given typically every 28 days, right? So it's pretty frequent, and you have to go in a lot, and they tend to be, for most people, they do it on a 7-day schedule, meaning you go in 7 days in a row, which is time. So the oral version is trying to get rid of those kind of problems for patients. Now, that's great. There are some things we need to consider, though, when giving an oral drug is, when you're getting the IV drug, you're going in and a nurse is seeing you every day and they're asking how you're doing and making sure everything is good. With the oral drug, it's pretty common that people will forget, right? We all can forget our medications because if they're in the pill bottle, you go out, to dinner, you forget, you're like, oh, I'll just take it another day. But that's not necessarily the best way to, make sure you're treating the disease, right? And it's not the fault of the patient in particular. It's just how life works. So when you have a schedule and you have to go somewhere, sometimes it's easier not to forget. And the other thing is, while you're getting treatment, you may need transfusion still. But if you're not going in, they may not be checking your blood as much. So some of the things still have to be adjusted, and your doctor still has to take pretty seriously to make sure that you're checking your blood frequently enough that if your blood counts go down on treatment, that you're still getting that follow-up. So it takes away some of the problems from these medications, meaning having to go 7 days in a row, but you still need pretty close monitoring even if you switch to that oral drug. So important things to know about this type of drug, and these are the things that I tend to talk about in clinic a lot, but it's important for everyone to have a sense of this upfront before starting any of these therapies. One is that they work pretty slowly. So, they're not like an antibiotic where you have an infection, you take it for 14 days and you're better, right? So azacitidine tends to work, and we tend to evaluate after 6 months. That's a long period of time. We know that if you start looking for results too soon, you can actually end up fooling yourself, right? If you look after that first month, I told you that your blood counts can be worse. Now that sounds counterintuitive, but realistically, there's the effect of the drug itself too, right? So till your body has the capacity to start remaking cells and making them as well as they can, you might have a dip, which, patients feel worse and then they think it's not working. But it takes time. So patience is a really key factor in treatment of this disease. The other thing is staying on the prescribed schedule is quite important. And of course, there are small deviations based on, if you've discussed it with your doctor, things can change, right? But it's really important to try and stay on that schedule. And why is that? Well, one is we only know the drug works in the way that we studied it, right? So we gave it for 7 days. and then over a 28-day period. So, on day 29, which is about 1 month, you're getting it again. Now, they've looked at many different scenarios where, can you take a break for the weekend? Yes. So you get 5 days and you get 2 days the next week. That's fine. But what we do know is that, for example, after that 28 days, if 28 days actually becomes 2 months, your risk of relapsing or the disease becoming worse is actually high. So it's almost not, worth doing it in a super interrupted fashion unless there is something else that is causing a problem, right? So if you have a big infection and you can't stay on schedule, or your doctor told you that you need to change the schedule, that's different. But our goal is to keep you as close to schedule so you can get the maximum benefits from the drug. And then one unfortunate truth that I think is important to discuss is, even in the best case scenario, which is like, the patient who is completely healthy otherwise, everything is going well, this drug only works in up to half of patients, right? And when it was looked at in more patients, like, with other problems, because most of us have more than one problem, right? The number actually can go further down. So maybe about 30% of patients responding. Now, it's really difficult to tell a patient, 30 to 50% of people will respond, right? They're like, well, what if I don't respond? And a big part of what the scientific community is trying to do is figuring out like who responds and who doesn't. And this is a major driver at research that we're doing at Sylvester as well. But we don't have a good answer for that yet. So that's something sort of in the works, something we're looking at, right? And so our current approach, even though this seems kind of archaic, is you give it to everyone and you hope for an improvement, making sure you're doing the assessments at the right intervals so that, if someone's getting worse, you pick it up right away and you switch to a different path, okay? And then, like I said, there's no perfect test. And in those who do end up responding, these drugs can actually lead to an improvement of quality of life. And we have good evidence for that. So don't be discouraged by, that first 1 or 2 months where you're needing more transfusions, because over time, that can very much equilibrate to a level where you're not needing that extra stuff and you're making the good cells again. But one key thing I'd like to mention is that, your doctor may or may not mention this, but it's really important. These therapies, these approved therapies, are of something called palliative intent, right? And that's a big fancy word for saying that we can control the symptoms and we can control the problems, but it doesn't end up curing a vast majority of patients. And at some point, the disease will likely come back even if you get a good 6 months or a year or 2 years out of it. For most people, the disease will come back. And at that point, the conversation changes, right? So again, I just wanted to make sure that people understand is that this drug does not necessarily cure you. For most people, it doesn't cure you, but it prolongs survival, so people live longer. And for many people, it'll improve the quality of life in the longer term. I mentioned this before, but it's really important to sort of reiterate that using these drugs appropriately, so not bouncing back and forth between drugs, staying on schedule, getting the right doses, really, really important to make sure you have the best chance of being one of those people who ends up responding or doing well on the treatment. So what's next in MDS? This is a big topic because, like I said, we only really have a few drugs that are working so far, right? Despite how advanced science has gotten, how many drugs are out there, there are only a few that are really working in MDS. And how do we get there? So a lot of the newer drugs, or the drugs we're sort of pinning our hopes on, are in clinical trials. And that's why when your doctor sort of talks to you about participating in a clinical trial, if it's feasible, it's definitely worth a thought or worth considering, because that's where the newest drugs really are, right? And anything that's getting to a point that they're giving it to a human being has been through a lot of testing. First in the lab, then in animals, and then in some healthy people in many cases as well. So, of course, there can be side effects of any drug. There, may not have the same amount of data to show you, like I showed you those nice clean graphs, but it's all based on evidence, and we're hoping that it's going to be better than just the Vidasa alone or the Dacogen alone or any of those one things. So I think my big, every circumstance is different and every person is different and every decision is very personal. But I think this should be a joint conversation. And, even if you're not really into the idea of a clinical trial, I think it's worth having an in-depth conversation with your doctor when they're available, because they may be better than what's available. So beyond that, obviously people want to know, well, how can I be cured? And in some cases, this is not possible in current modern medicine. And I feel sad saying that, and I hope that will change over the course of my career. But at this point, I cannot promise every MDS patient I can cure them. But within certain circumstances, and Dr. Jimenez will talk about this a little bit later this afternoon, but transplant can actually cure some patients. And it's always worth considering, well, is someone fit enough to go to transplant? So we talk about transplant maybe a little dismissively, like, oh, it's just a transplant. But it's basically hard chemotherapy and then getting cells from somebody else, so a whole brand new immune system from somebody else. And that can be pretty deadly. So the patients who can actually do well with that, which we historically know are generally younger patients, generally. That's changing. But definitely patients who are more physically fit. So at this point, if you're 90 years old and very physically fit, I think a transplanter still will say no. But in the older days, if you were 60 and you had one other medical problem, some transplanters might have said no. But now, even at 70, sometimes 75, they would consider it in the right patient. So definitely worth talking to your doctor about, is transplant the right course for me in those patients who may benefit from it. Because technology, our supportive care, meaning not just the treatments that we're giving, but all the other things are getting so much better that I think we might actually have a shot at improving survival longer term. And then other things we tend to talk about less because we get so focused on the science, right? So we've talked extensively about how MDS is usually a disease of older people. So older is relative, but people over 50 or 60. So things that your doctor should be thinking about, and you should bring up if you don't feel like it's being discussed, is, most people have more than one health problem. How does this affect my heart disease? How is my high cholesterol important in all of this? And some of those things you're going to say like, okay, well, these are chronic problems. They're not changing anything. But, many people are on 4 or 5 different medicines before they get MDS, right? And so managing those MDS-related problems with the non-MDS-related problems and making sure those meds are not interacting or not causing too much difficulty to the patient is really, really important. Another thing is when you're tired and you're not in the best mood, some people are, and also just all of the things going on, the physical stress. People are not necessarily as hungry. Their hunger might change also because of the disease itself. So malnutrition is a big problem where you're not eating enough. If you're depressed, you might not be eating enough. And depression is a big problem in MDS because it's suddenly you felt fine, and fine is relative. You were a little bit more tired than usual, and you went to the doctor, and they told you had cancer. That's a huge stress. So coping with that is a big problem, right? Now, as we know also, as you get older, your mobility may not be the same. You may not be able to do the same activities you could when you were 15 or 20 years old. So that's definitely a consideration for MDS, because even when I'm thinking about giving a patient Vidasa, for example, I have to be very careful that, for somebody who's already prone to falling down, if I made their red cells lower and their oxygen levels lower, they might get dizzy and fall down more. So do they have the right equipment or the right family support or the right everything else to cope with those changes? So sort of considering this into treatment is very important. And then other things are, unfortunate, like over time people maybe develop a little cognitive decline, right? We all start forgetting things as we age. But cognitive decline on its own tends to be something more serious where you're not able to retain as much information. You may not understand your treatment as well. So these are all things we need to think about when we're starting treatment to make sure that, one, the patient fully understands what's going on, but also that it's not causing other problems. Because we have to think of every person as a person and not as their disease. It's really easy to get labeled by the disease, but the person is the most important. And then again, a sad sort of situation is that cancer care is expensive. And some people have planned for this and some people have not. And even if you plan for it, it is still exorbitantly expensive. And just managing those consequences, how that affects the family structure is really important, right? So hopefully, for most of you, there is some resource to try and help or at least, consolidate care, make sure that, we're making the best of the situation. And again, I kind of mentioned depression as one thing being pretty common and patients get diagnosed with MDS, but also just that sense of isolation, right? Just suddenly you feel like you're not the same as your friends. You have a disease that has labeled you in a way. When you're tired, you may not be as independent as you were. You may need somebody to drive you. So that loss of control over your life a little bit can be very stressful as well. So having mental health support is kind of a big part of thinking about, disease and how we manage things. And in general, I kind of have alluded to this a few times, but in general, people with MDS actually end up having more comorbidities, so more other problems. Heart disease, lung disease, arthritis, things like that, than people who don't have MDS. So again, these are really relevant because we need to consider all of these factors when we're planning care. So kind of coming back to this, treating a person is a team sport. And there are many, many people involved in this care. So make sure that you're getting the best of every resource that's available to you, right? From the doctors to the advanced nurse practitioners who work with them, to the social workers who can help, get you the right resources in terms of, do you need a wheelchair at home? Do you need somebody to come in and help you with routine tasks? All of those things, we have resources for that. And, amazing foundations like AMDS help provide some services as well, or point you towards the right resources. So, making sure that you have what you need to treat your problem as opposed to the diagnosis as a blanket is really, really important. So, for me, I'm presenting this information, which I usually present to other physicians, as a gentle reminder about how you want to be treated and how you want to conduct yourself. But it's important for me to sort of tell you what I'm talking to other physicians about, right? So one is to make sure you're clearly telling people that MDS is in fact a cancer. Every cancer is different. Every cancer does not become something that leads to death, but it is a cancer. And for people to know that is just, it's empowering them with the correct information, right? And also there should be some transparency in terms of when you're talking to a patient. It can't just be like, oh, you'll be fine. You need to explain, just like we've been talking today, and everyone will, need a slightly more personalized conversation with their cancer. But you need to be able to express what's going on, what are the key problems, and how are we going to deal with them. So this is something you should feel free to discuss, point by point with your doctor. Then we have to suggest a plan of care and pause for your questions. So, I can explain a lot of stuff, but when I just told you you had cancer, and then I told you you have all these other problems and here are your 10 appointments, That's a lot of information to process real fast, right? So we have to make sure that even if it's not within one visit, within a few visits, we kind of repeatedly talk about things so that they have time to sort of filter and, for processing. We need to review the plan again and again because all of us forget things. And it's really important to make sure someone knows what they're doing, why they're doing it, and understand their disease to a certain, a level. Then I often suggest to patients and other providers is to, if someone has a companion who can come with them, to bring them along because 2 minds are better than 1. 2 sets of ears are better than 1, right? You'll all catch little different information and then you can put it together after. So having a family member, a friend, someone who cares about you is really helpful in that process. And then, this may not be at the first visit, but also providing some reading material because all of us, we've learned over time, right? All of us process information differently. So some people will hear better, some people will read better. It just gives that information in little pieces so you have different ways to process. And then finally, in Miami, we have this as a big thing, is making sure that patients receive this information in their primary language. So many people here speak Spanish as a primary language. And, some providers won't speak Spanish, but it's really important that then they bring in an interpreter or translator to explain everything, because if you don't understand what's going on, it shouldn't be because they weren't speaking the language you speak. So I think all of this feeds into this concept of patient-centered care. So care should be respectful and responsive to everyone's individual needs, because we are not one person, we are not one disease, we are all a little different with all different issues or values or principles, and we should be thinking about that when we're trying to plan your treatment. And then again, this is sort of a side note, but this is really important. Caregivers are the unsung heroes in all of cancer care. That person who drives you to your appointments or who helps with getting you to your transfusions or, all of the various things, coping at home, because, this is a big diagnosis. So for them, in addition to the patient, we always have to kind of check in and see, how are you doing? Because, this can be a financial burden. It can be a burden in terms of all of the stuff we all have going on. Who's taking care of the kids? Who's cleaning the house? Who's cooking? All of those things. And, the patient is number one. But make sure you're spending a few minutes with the caregiver too, just to make sure that things are managed, because a good home environment can be better for a patient in general. And try and minimize their emotional and physical stress the best we can. It's not a perfect system. We can't always offer solutions to everything, but at least we need to try. And with that, I'd like to thank you all for coming today and just listening. And I'm happy to talk about any questions you have. Go ahead.
Okay, I'd like to put you on the spot.
Sure.
Okay. You're in the business.
I am.
Who are the top people in your business, and where are they?
So it's kind of hard to say. Okay, so the question was that I'm an MDS physician, and who are the best MDS physicians? I will counter that by telling you that, like I said, we shouldn't just be treating a disease, right? And to treat a person fully, you need to be in your best environment. Because if you think about it, for most people, this is a chronic disease, right? Not the higher risk, like I said, some people have a very poor prognosis, but if you're lower risk or you're in that in-between, you don't need to move your entire life for a physician. Because that may mean moving your life for 6 years, 7 years, 10 years. I think the best advice I can give you is that if you do not feel comfortable with your care, or if someone is not an expert, I usually recommend that you have a second opinion, perhaps at an academic medical center where, someone is focused on one disease. Like, Dr. Sekaris was focused on one disease. I'm focused on one disease. We all focus on a particular topic, so we spend all of our time thinking about people with your problem, right? And so I think it's not about one person being the smartest or best or any of those things. I think it's one, making it best for you. And what is the best care close to you? Because again, driving 2 hours to your appointment is not going to be therapeutic for many people. You can always have a second opinion and, discuss with someone locally to actually provide the care. But make sure you feel like your doctor is listening to you. I think that's a no-brainer. And sometimes we can't give you the answer you want, but one, that you're listened to, two, that we're trying to answer your questions, and three, is this person, do they feel comfortable? So I think it's very fair to ask your doctor, are you comfortable with this diagnosis, or do you think I should have a second opinion? And I think most great physicians will be like, sure, have a second opinion, and then it's two minds thinking about it.
I think related to that is that you talk about trials.
Mm-hmm.
I don't know, I haven't found any trials going on around here. So should I be looking to go to Houston to the Anderson Clinic?
I see your question.
Seattle to their clinic?
Yep. So
How do I, as an individual, even evaluate whether it's worth the hassle, the expense, whatever, to get in my car and drive to Houston and knock on somebody's door?
yeah, no, that's a great question. So the question was, how as a patient do you find trials or find resources, I guess, to point you towards the best treatment, right? And there are a few ways to go about this. So I think the one thing is almost every academic medical center will offer some trials, right? So you should basically talk to someone like Dr. Sekaris or myself at Sylvester, because what we can end up doing at any big academic medical center, we are aware. The community is small, right? We talked about this being a relatively rare disease, and we all kind of know each other. So one of us could help point you towards a trial that, for example, might be available here. And if there's something way better somewhere else, we can tell you, hey, this might be worth exploring, right? And again, we never know if a particular drug is going to work for someone or not, right? We have a good guesstimate. That's what I would say. We have scientific rationale. We have a reason to try and think one drug might work better for one person versus the other. But what our job as MDS doctors is to make sure we point you to the right resources and see if you're able to make those. Trials are not the only thing that are better than everything else, right? Sometimes just keeping on that transfusion course might end up being the right move for you, because you would have to move your whole life, find a new home, separate yourself from your family, your friends, and everything, and that takes a big toll as well. But having that conversation with somebody who's a part of that community, so somebody who identifies as an MDS doctor in particular, maybe beyond a general practitioner, might be helpful. So short answer to your question is any big academic medical center can help point you to the right resource. And I can't tell you what trial is best for you right now, because I don't know every specific about your disease. But if I were seeing you in clinic, I would look and think, oh, what do we have here? And then what other things might benefit? And then we would discuss it, whether you did it or not.
Do you have the time to set up for a 10-minute discussion?
Sure, but I think, yeah. Okay. Alice, go ahead.
What I advise most of the people that I talk to that have MDS or other diseases, the most important thing is for you to educate yourself.
Correct.
And the second most important thing is to become your own advocate. Learn all you can about the diseases, and then become an advocate.
I agree, yeah.
Don't think this is the only way. And for clinical trials, which I've never participated in, by the way, that website up there, aamds.org,
Mm-hmm.
get into it and join it, and they'll let you know what's available. They're a great group.
I agree. So the opinion here was basically that you should become very self-aware about your medical care, right? And
Why God created the internet.
right. So I'll say one thing. So one, a lot of those points about talking to your doctor about all your other medicines, your other medical problems, your specific disease, your particular mutations is important, right? I do think the internet has some wonderful resources. I will caution you that Facebook is not one of those resources. Twitter may not be one of those resources because you'll see, a big spectrum of patients being like, I was cured with nothing, and then other patients saying, I died, or not, my relative died in 2 weeks or something. So it's the scariest situation or the best situation. And you want to think of a realistic situation. So you want a source of information that's vetted. And that's why foundations like AMDS are great, right? Or other MDS resources, essentially. Or information that's coming from medical websites, meaning, look at our website or look at any other academic center's website, because we all have like an information page about generals of disease. And then more specific details, again, have to be tailored to your care in particular. Go ahead. So great question. So there are a few things, right? There's some of the same sort of elements that we were talking about in higher risk disease. We're looking at your blast counts, right? Which are those abnormal cells. And then we're also looking at your other blood counts, right? And when you put all of that information together, that's what essentially tips us towards whether you're progressing or you're becoming more AML-like, okay? Now, how do you manage? The second part of your question was, how do you manage that, right? Or how does that happen? Right. It generally happens because of a few different things. One, like I said, the environment in your bone marrow is essentially not the most hospitable, right? So it's an environment that's a little bit more prone to developing additional mistakes. And those mistakes are called mutations. So some of them we know about, others we're learning about, but that's one way. The other thing is, how these mistakes survive, right? Because our body actually makes mistakes every single day, but usually your immune system catches them. The cell that becomes MDS or CMML or any other disease is basically your immune system was kind of tricked and didn't see the mistake. And sometimes when it didn't see the mistake, there's like this cell that's just kind of hanging out there. And in that scenario, basically that cell has the ability to acquire more problems or more mistakes. And by this point, your whole body is kind of used to that cell, so it's not registering it as a mistake. Okay? So it's usually a change either in one of your stress markers, and when I say stress, it's not like, stress emotionally, it's more like getting an infection, getting sick, any kind of cellular stress, right? Radiation, chemicals, all of those things can be stress. Many of them we don't even feel. But any kind of stress can cause it to evolve. And by nature, just having that one mistake makes you more prone to having a second mistake. Great question. Yeah. Sure. So the question was, when is low-dose chemotherapy used? And that's an interesting but hard to answer question in particular, because I'm not sure which chemotherapy, right? So for patients who are basically becoming more AML-like, meaning their blast counts are going up, their cells are not responding, that's when we start using more of what we call traditional cytotoxic therapy. Basically just means those hard drugs, what we traditionally called chemo. So hypomethylating agents or the drugs that I described are not hard chemo, right? There's a mechanism and they're a little bit gentler. But that hard chemo tends to be given to patients when their blast count is going up, or there are other features that are more concerning for development in that AML direction. So that's what I would say as a general rule. It more depends on which drug. Yeah.
And another question we received is, do you have patients with MDS del5Q?
Absolutely. So del5Q, Dr. Secker has talked about a little bit in the low risk scenario where, we have a really great drug, which was the lenalidomide, which works in a focused kind of way in that population, right? When you start having more blasts or other mutations that go along with the del5Q, they tend to become less responsive to that treatment that used to be a wonder drug. They might still respond, but it's just not as effective in this higher risk, already on the road to becoming AML kind of disease. So yes, the question was, do I have patients? And yes. Yeah. Other questions? All right, great. Well, thank you all. And I think my general contact information is on the screen, just how to get in touch with us at Sylvester if you need us. And it was my pleasure speaking with you.
Thank you, Dr. Chandok, for sharing your time and expertise with us. If you would like to watch this session again later, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If you were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDS-IF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan future educational programming. We will now be breaking for lunch and returning for the next educational sessions at 12:45 p.m. Eastern. If you are participating online, you can eat lunch and chat with others in one of the discussion groups. You will find the discussion groups in the Community tab. This is also an excellent time to visit the exhibit hall. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDS-IF Medical Advisory Board and team are here to help you and your family, as we have for the past 39 years. This concludes the session.